Welcome to the Metabolic Link, a podcast that explores the common thread of metabolism in health and disease. This is where science meets society. Welcome to the Metabolic Link. I'm your host, Dr. Dominic D'Agostino, physiologist, neuroscientist, and metabolic researcher. Today's episode is about metabolic health, surgical innovation, and what it really means to optimize healing from the inside out. Today, I'm joined by a friend who's really redefining the future of surgical care. His name is Dr. Cameron Chesnut. Dr. Chesnut is a facial plastic surgeon trusted by high performers around the world. His results really speak for themselves. It's natural, rejuvenated, and seemingly untouched outcomes through minimally invasive procedures. He is known for integrating regenerative medicine, metabolic science, and next-level recovery techniques, along with a personal performance protocol that is as dialed in as his surgical practice. In this episode, we go deep, and you'll hear about Dr. Chesnut's how he designs opioid and benzodiazepine-free procedures, protecting the brain from anesthesia, a major concern for older people, and enhancing the healing process with tools like ketone therapy, hyperbaric oxygen therapy, red light therapy, IV nutrition, peptides. So we actually connected because of the ketone enhanced wound healing studies that we did. So we talked quite a bit about that. We also break down his personal routine and how he prepares for surgery like an elite athlete. It's unlike anything I've ever seen. So he does fasting, he does breath work, he does glucose tracking, and he mentally rehearses the procedure when he shows up on game day for peak performance at his trade. So Dr. Cameron is actually stayed at our house on our farm for several days, and it was so much fun to just pick his brain, to lift weights together, to just hang out with him. One day he helped us get hay for our cows, and the girl behind the counter asked if he was my son. So true story. Cameron's in his 40s. So whether you're a physician, an athlete, interested in surgery, anesthetics, or just curious like where modern medicine is headed, this conversation is packed with insight. So before we get into this episode, I want to say a special thank you to our sponsors. They are Genova Connect, Fatty 15, and Zocdoc. They help make this Metabolic Link podcast possible. We really appreciate you visiting their websites and trying their products. These are all products or services that we vetted out and personally use. And if you like this episode and you want to see more of it, please don't forget to subscribe. Now let's get on to the episode. Dr. Cameron Chesnut, thank you so much for coming to our home and, connecting with me a few months ago, I guess, and it's been a while to really do an in-person interview.
Yeah.
Thank you.
Very grateful to be here. Thank you for having me.
Yeah,
very honored.
Thank you. I appreciate you being here. I have a lot of questions, and you sent me a lot of various topics to cover on this. And I think what would be really great for our listeners and or watchers on YouTube here is to give us a background maybe on how you got into the path that you're currently on, which is very unique. So you practice facial plastic surgery, almost like a metabolic regenerative approach with modalities that I didn't even know would be considered for plastic surgery and recovery, and some modalities that I'm very familiar with, like ketone metabolic therapy, hyperbaric oxygen. So, but let's take a step back and maybe talk, we'll go to your childhood or wherever you want to start, but undergrad. So we both share the passion for nutrition, and we majored in nutrition as undergrad. So maybe let's start there and tell the listeners how you...
Well, working a little retroactively, my practice now, like you said, is facial plastic surgery, and it is... just to lay the groundwork, is my practice is very destination based. People fly in from all over, and that gives me the ability to have an experience with them that they're with me for about a week after a few days before and a week afterwards. And so I have this beautiful opportunity to be creative and experiment and really work on their recovery while they're with me. It's a very proactive approach to it. And I do that for faster recovery, but ultimately, almost in a selfish way, it's for better results for us too, right? And that really has when we look at it, it has the recovery component, and that bleeds into the procedure itself, and then it bleeds into the pre-portion. And that's where the metabolism really permeates through all of those things. And that interest, like you said, in regenerative medicine and metabolism is very founded in my childhood, where my mom was a nutritionist, a very traditional registered dietitian. She worked for the state, she saw patients, and then she became sort of a leader, more of like a leadership or management role, and didn't really practice as much anymore. But I was always very interested in performance from an athletic standpoint, and that's what really kind of got me interested in the physiology behind nutrition. And my mom was kind of the crazy mom at the time who did time restricted eating before it had a name. We're talking like she trained in the 70s in the era of the food pyramid and margarine and canola oil, and she was very much trained in those things, but also very anti them, but in a kind of a kooky, fun mom way, not in a very, vocal way. And so, I grew up in a house without soda and without, these types of bad fats that we kind of know now that at the time were very in fad. And that kind of stuck with me a little bit, whether she knows it or not. And it went through collegiate athletics and endurance sports and into medicine. And, I first came across you actually as part of this journey right when I was starting my actual practice, done with residency, done with fellowship, getting into the real world, and very interested in my own performance in the operating room and my patients' sort of performance, if you will, in their recovery. And that's quite literally where I first found you.
And your residency, talk about where did you do that in your fellowship?
I was down at UCLA I was in University of Washington for medical school, so I'm very West Coast, and then I was at UCLA for residency and fellowship. And, they were very progressive fellowships or training, fellowship and residency in the sense of the procedures that we were doing and who I was training with and where I was training in Beverly Hills. And but when it never across the way, including in medical school, was there a big focus on nutrition particularly. We did have a nutrition class in medical school, but having been a nutrition major, it was very underwhelming. And then in training, it beyond just the normal recovery parts of surgery that were just very standard, I would say, there wasn't a big focus on metabolic health around recovery. There wasn't a big focus on even things like hyperbaric oxygen around recovery, unless there was an issue, right? It was used it was like a rescue treatment, but not used in a more progressive, proactive way.
And, and hyperbaric oxygen is approved and covered by insurance for wounds that don't heal. Correct. So we know that it augments and enhances the wound healing process. And work that we've done, it shows it in like a ischemic model and in young healthy too. So you're kind of ahead of the curve and kind of approaching it from, just an optimization standpoint. And I think your, I would describe your whole practice as just like, plastic surgery, pre-op, post-op, optimization, for the patient. And you also do a protocol to optimize your performance as a plastic surgeon, which is unlike anything I've ever heard of. Your whole morning protocol going into that. This episode of the Metabolic Link is brought to you by our friends at Genova Connect. So I've personally been using their testing. I really like the Metabolomics Plus panel. I found it to be incredibly insightful for understanding nutrition and metabolism at a deeper level. It goes beyond the standard labs to reveal actionable nutritional insights into the metabolic pathways. It was really interesting to see how ketogenic diets influence these metabolic pathways. It's helped me connect the dots between diet, performance, and metabolic health. I've also added the essential fatty acid testing to the kit and also heavy metal testing, which are add-ons. So you do a sample, it does a urine sample and a blood spot card measurement that you send in. And if you want a clearer picture of your own biochemistry, check out Genova Connect, and they have a wide range of different tests that are available on their website. So I encourage you to visit their website, go to gdx.net/the metabolic link to learn more and use the code metabolic link for 15% at checkout. That's Metabolic link spelled out in one word at checkout for 15% off of any of their test kits. Now back to our interview with Dr. Chesnut. So you've touched on, you sent me a lot of notes, and I want to make sure we hit on ones, and you've done some fantastic podcasts before. Yeah, but we're gonna, and they were amazing. So listeners, check out the previous podcasts on many different things when it comes to fillers and Botox and a lot of different procedures that you do. So I have maybe some questions about that, but a lot of things that you maybe didn't cover on other podcasts. And one that really caught my attention, and you had reached out to me about it, is just really the surgical recovery from anesthesia as it pertains to the neuroinflammation and the cognitive effects. And a lot of people are not aware that anesthesia is pretty serious and potentially cognitively detrimental, like to the brain. So you have an understanding of that, and maybe tell listeners what you do that's quite different.
Yeah. So, generally the whole way that a surgery works is you have your surgical team and your anesthesia team, and although they're in the same room, it's sort of very separate things. And this is one of the benefits of being in an elective surgical setting where it's my team that's built around me, my surgery center, is that I get to be very collaborative with my anesthesia team. It's not sort of they show up and who am I working with today? It's the same people. And there's something called post-operative cognitive dysfunction, POCD, and it's, I would say, significantly under talked about, and not a lot of people know that name, but everybody knows what it is. And that is the classic story of, you're healthy and young and you have surgery, and for 4 days afterwards you're foggy and I just couldn't think straight. Or on more extreme examples, with older patient populations, they can get pushed into early cognitive decline types of settings, or dementia, or and
not recover. I've gotten a number of emails about this, and that made me paranoid about older people that I know, my parents in particular, undergoing general anesthesia for that reason. Yeah.
And we also know that in young kids who are exposed to anesthesia, usually repeatedly at young ages, that they tend to have lower cognitive function later on, lower IQs, and that's well documented and well known. And like many things in life, I believe there's black and white binary, but a lot of things exist on a spectrum somewhere, and this falls into that most certainly. And that's the idea that even you and I, who are healthy and have a lot of cognitive reserve, if we have surgery, we're going to probably lose some of that cognitive reserve. And in the studies looking at aging after elective surgery, that was one of the biggest protective mechanisms against cognitive decline over time, is how intelligent you were going into the surgery. But that doesn't mean there's not a change in it, right? And so it makes you curious, or makes me curious, to look at, well, what's happening here? Are there certain agents that are responsible? What's the mechanism? Is there a way that we can optimize this? Because in my world, I'm working with young, healthy, high-achieving people who are having an elective procedure, and it's not worth the cognitive or neurocognitive decline to have that done. It just sort of makes sense. And so I started really digging into this, with my anesthesia team, and sort of really feathering out what types of anesthetics we could use that would achieve the goals we're after, and not only limit the post-operative cognitive decline, but protect against it instead, do the opposite. And it turns out that a lot of it's driven by neuroinflammation. That's what really happens afterwards. Some of that neuroinflammation is from the anesthetic agents themselves, their direct effects on the brain. Some of it is from regions of brain hypoxia, and the post-inflammation that comes with that.
Hypoxia, reperfusion, ischemia, kind of things.
So not, breathing, some of them slow down breathing, and then regions of the brain aren't as well perfused. There can be vasoactive effects that cause that to happen.
Then you have the inflammation cascade from the surgical procedures or whatever, so sort of further enhancing that too, right?
Yeah, the peripheral inflammation affecting what's happening in the central nervous system. And as we dig into that, we look for agents that are neuroprotective in their anti-inflammatory effects, or ones that don't cause as much in the first place, don't cause as much hypoxia. And turns out, the regimen that I use now is very thoughtful about that. And I'm using a cocktail of very low dose of multiple anesthetics to be able to achieve this. I do not use general anesthesia. So we know that the inhalational agents that are used in general anesthesia are the most notorious to cause these postoperative cognitive dysfunctions. And some of the other agents that come through an IV are significantly less so, if not protective against it. And so those are the agents I'm choosing. I do have the benefit of the procedures that I'm doing being very amenable to using just local anesthesia. And what I mean by that is that when we're working on the face, which is the only area that I work, we can do these procedures with local anesthesia almost alone. So I could do a lot of these things theoretically with my patient awake. Now, we wouldn't do that for the reasons of anxiety and just kind of patience and things, but the procedure could actually be performed with them awake, and so I get to use a combination of this local anesthesia and some, some more IV types of sedation, and that allows me to keep anesthetic doses low and use the benefit of the local anesthesia, which has another central effect on pain afterwards, and really have a way to move forward without, with protecting against, but also, knowing that we're not causing much of this POCD.
And the local anesthesia sounded like, I wasn't even familiar with, and I teach about these drugs, but like you have your own sort of cocktail of a lidocaine-like liposomal sort of, drug that you put on the skin, and that sort of, can minimize the use of IV, and reduce the risk of other heavier,
and that goes into the post-operative pain part of it as well. So we have the intraoperative portion, and then kind of quite literally the very last thing I do in a procedure. Everything is done, and I'll use a long-acting local anesthetic that's in the liposome, and which just makes it last longer, if you will, for lack of a better term. And then I do a regional nerve block in all the areas that I worked, and that gives about 48 to 72 hours of pain, we'd say elimination or reduction, which gets most people through the window of the acute part of the pain after a procedure, which is usually 24 hours. And the goal there is that they don't need any post-operative opioid medications. I don't use any during my procedure. I don't use any benzodiazepines or opioids, and the goal is to not need them during the procedure or afterwards as well, which comes usually with sleep and with pain. And so we're really being proactive about the issues with sleep and pain after surgery before we even start and during the procedure.
So that's amazing. So you've developed a protocol that has worked, time and time again for your patients, that's opioid-free and benzodiazepine-free during surgery and then post-recovery. People get a teeth pulled and they get sent home with,
the most common agents to use during surgery are an opioid and a benzodiazepine. Those would be the most common agents used for the types of procedures that I'm doing, and I don't use any of those at all. And the goal is not to afterwards either.
So those drugs, have their place post-operatively and things like that, but if you could you build the tolerance quick, you get dependent on them very quick, and people like the way they feel, and then and it's just a lot of people's pain management often leads to dependency and then addiction to these drugs, and when they can't get it, they seek other modalities. So
and they have a role when used in anesthesia in having higher rates of post-operative cognitive dysfunction.
That's a big one.
And then honestly for my patients too, again, there's an experience to this where even just bowel and bladder function, not having an opioid in the post-operative period, you have better bowel and better bladder function. It's a more pleasant recovery. Not only is it comfortable, but then you don't have those issues that that are notorious with opioids.
Constipations. For opioids is huge.
Urine retention.
So, and then you focus a lot on sleep, I know personally too, and then sort of the drugs that you use play a big role in restoring that sleep architecture and sleep hygiene, sleep architecture, and then that plays a big role in the recovery of the patient, from the procedure.
So I tell my kids this all the time, that sleep is our superpower, right? And it's important in the postoperative period for a lot of reasons, for partially the experience, but then of course as we get into the physiology of what's happening with the inflammation and the healing, we need that those types of deep sleep, and they are very much disrupted with normal anesthesia, and that's a very common thing that people hear about and have experienced but have never kind of put their finger on. It's not really talked about. But two of the agents that I'm using very specifically are mimicking the two phases of non-REM sleep before we get to it, 2 and 3, and that's the 3 is the deep types of sleep that we really want. That's the most restorative type in the postoperative period. Yep. And it's interesting because I'll have patients who are very in tune with their biometrics. Let's say they're wearing an Oura ring or something like that. And they'll notice that in the immediate postoperative period that their deep sleep goes up from what they're used to. And especially when they're paying really close attention, they can see these things happening, and something like their HRV will be really high in those initial phases. And that's actually sort of just from the medications that they receive during their procedure. They'll have those initial changes, because then what tends to happen, as we would expect with a healing and inflammatory phase, is that their HRV would drop after that, which you would expect in a stressful sort of healing environment. But initially, which is, we have these metrics to show it, initially it's improved, actually. So kind of counterintuitive to what you'd think.
This episode of the Metabolic Link is brought to you by Fatty 15. Most people haven't heard of C15 fatty acid, but it is an essential fatty acid like omega-3s that our body needs to function at its best. Essential fatty acids are crucial for brain function, hormone production, immune response regulation, skin health, and proper cardiovascular function. Unfortunately, modern diets leave most people deficient in especially C15. For example, you are more likely to be deficient in C15 essential fatty acid than any other essential fatty acid. So that's where Fatty 15 comes in. Fatty 15 is an essential and effective way to boost C15 levels back into the optimal range. Research shows that C15 strengthens the cellular resilience by enhancing cell membrane function and also mitochondrial function and resilience. For me, this has been an easy add-on to my daily routine, especially when I'm traveling and I'm not really eating foods that I normally eat. So you can get an additional 15% off their 90-day subscription starter kit by going to fatty15.com/metabolic link and using the code metabolic link at checkout. Now back to our episode. And that likely the sleep-induced physiological, neurological restoration plays a big role in the outcome of the patient and the recovery. And I know personally, and just from the literature, that a lack of sleep or disrupted sleep can trigger systemic inflammation, neuroinflammation, metabolic dysregulation. And that touches on another topic, is that a big lever that you pull is metabolic sort of enhancement through low inflammatory diet, ketone supplementation, ketone salts, MCT, and then hyperbaric oxygen too. Right. So that was a lot I just mentioned, but maybe walk the listener through how you implement this to mitigate some of the post-operative inflammation and enhance recovery process.
Yeah. So my practice really evolved, again, going in a retroactive type of story, my practice really evolved with this post-operative protocol that is very easy for me to do because I'm with my patients and I get to be with them and kind of guide them through this. And it's a very immersive, proactive, effort-heavy type of thing for them, but they're with me for the week. And so, and we're doing a lot of things to, everything kind of meets at the mitochondria. We were kind of saying offline to enhance the mitochondrial function, and we're doing that with light therapy and IV and hyperbarics and very targeted types of modalities like that. But if we go into the surgery itself, I'm using some of those, including red light and things during the surgery, but then in the pre-operative period. And we were kind of saying, this is my current love, passion, and exploration to optimize my patients, but it's more challenging because they're not with me yet. And so there's different ways that we'll go about doing it. And I'm trying to start everybody, about a month or if more before their procedure to let's get you optimized and ready for this. I kind of say I treat myself like a professional athlete in my preparation, execution, and recovery, and I want them to do the same. Imagine if we knew that LeBron James was going to have an injury on this day. We would be making sure that he is ready going into that injury to be able to heal afterwards. And that can come with things like a fast mimicking diet, a low inflammation diet, can come with some supplementation leading into it. And that's where ketones come into this, right? Because ketones help multiple aspects, one of them being the postoperative cognitive dysfunction afterwards by reducing the neural inflammation, which pairs beautifully with their hyperbaric oxygen, but also makes them just a little bit more metabolically flexible going into their procedure if they're accustomed to having ketones. And so there's a lot of benefits, but again, with focusing on that POCD, that's a big aspect of it. But it's a challenge to have patients adhere to all of those diets. A fast mimicking diet, decreasing calories and a little bit of food restriction has big benefits, but a challenge to do, especially if you're not accustomed to that. The anti-inflammatory diet's a little bit easier to follow because it's a little bit more like elimination and education. And I find really great adherence to that before and then afterwards, which is great. And then the ketones are usually pretty new to people. And that's a really fun one, actually, because I think a lot of people have heard about them and they know, but they've never experimented or played with them before. So it's a really great way to enter them into it in a very beneficial way.
And use ketone beta-hydroxybutyrate that's buffered with a monovalent or divalent cation. So that's a fancy way of saying a ketone salt. So you tend to use the ketone salts because the electrolytes are really good buffers, especially for that acid load, patients coming out of hypoxia, recovering. And you also use hyperbaric oxygen, and we know that therapeutic ketosis can mitigate potentially even better than anti-epileptic drugs the potential for oxygen toxicity seizures, which could be a risk for people coming out of surgery and things like that. So so you have the neuroprotective effects of ketones potentially like synergizing with the hyperbaric oxygen as in regards to wound healing, blood flow, anti-inflammatory effects. So you couple those two together, and that's kind of a unique, aspect. You're making hyperbaric oxygen safer, but also probably enhancing the therapeutic benefits of it.
Exactly. And the hyperbarics is a great example of one of these that's really directed. There's multiple benefits to doing it in a postoperative period. This is not unique to my type of surgery. Anybody under any surgery can benefit from this, especially if you're having general anesthesia.
But you're the only one that I've known that is using it for this application for just like, optimizing, brain function, but also the skin healing, and then the oxygen blood flow, and then even the stem cell, hyperbaric oxygen stimulates stem cell production and also mobilization into the blood. So you're enhancing multiple, aspects.
Which is one of the benefits of the pre-operative hyperbaric diets that I'm having my patients do. And you'll hear, and there's been studies even in the plastic surgery literature on facelifts about recovery times after say a facelift. And something that I see, and just anecdotally, I usually even tell patients like, after the week, you usually look like you're about at the 3-week mark. Like for if you weren't to do this protocol, and that the literature actually supports that. It's about about a 1/3 reduction in downtime, and that's great, and that's part of the experience, and that's wonderful. But that's also sort of I'm least interested in. I want my patients to have a great experience and heal fast, but I'm really interested in what's the long-term outcome of this procedure. And that's the most unique part of the hyperbarics, is that benefit to the long-term outcome. And the way that it does it with the hyperoxia in the plasma is that you get a vasoconstriction of the blood vessels. They constrict down, but you don't get hypoxia of the tissue, right? So that's a unique, usually those go hand in hand. The blood vessels squeeze. So their edema, their swelling goes away faster, which is great. That helps the recovery time.
So you're talking about hyperoxia-induced vasoconstriction. Which is, like I know about that. I have various stories about that. We'll talk offline about sort of observing that under different contexts, but so that I never thought about that as sort of helping to mitigate, the surgical and then the edema. And that makes a lot of sense.
That's what most patients notice immediately, is that they're swelling. And they, there's a mechanical effect of the actual, the depth or the pressure, but it is that vasoconstriction that really helps get rid of edema. They feel better, less pain, less swelling, because most of the discomfort after a procedure like this is just from the swelling, right? So if we can get rid of that faster. But then it also helps to temper the acute inflammatory phase that's happening. And so you get reduction of some interleukins and things like that, IL-6 or something that is important to that inflammation. As that gets tempered a little bit, it actually, this is the best part, is it makes the healing better. And the best way I can say that is you get better collagen and elastin, elastin being the hardest to produce. We get better elastin production. You get new blood vessels, you get all those things, but there's been studies showing that the scar reduction or the fibrosis is less. So in models of, let's say, orthopedic surgery or limb surgery, there's better mobility of the wounds postoperatively with hyperbarics. And so in our face, that's, again, not been looked at, but wildly important is that we get less scarring, less fibrosis, and tissue moves better. Well, the better our face moves, the more natural your results are. And so these little micro improvements are really what I love about it in the long term. I also use a lot of fat transfer or fat grafting, where I'm borrowing fat from one area and I'm moving it to the face, usually the abdomen or the flanks. And that becomes a free graft.
Autologous for the most part. So adipose-derived stem cells.
Yes, right? Exactly. So in that fat are our adipose-derived stem cells. And so I tend to select for that. And we were kind of talking offline, I'll kind of like get rid of the fat that's a little bit more mature fat cells, and I'll choose the stem cell-rich portion. And hyperbarics, this is evidence-backed as well, hyperbarics helps the survival of those cells and once they're transferred, because they're taken from their blood supply and put in an area where they have to reestablish it. So, which they do by creating new blood vessels and all the things that hyperbaric supports. So now we have another mechanism to improve the results with the fat grafting, which is often an important part of the procedure.
This episode of the Metabolic Link is brought to you by Zocdoc. When was the last time you needed to go to a doctor, but you pushed it off? You made an excuse. I'm too busy. It's going to heal on its own. Since turning 50, I realized that I needed to see a dermatologist. I needed to see an eye doctor. I needed to get a colonoscopy. To book that, Zocdoc made that super fast and super easy. Zocdoc is a free app and website where you can search and compare high quality in-network doctors and click instantly to book an appointment. We're talking about booking in-network appointments with more than 100,000 doctors across every specialty, from mental health to dental health, primary care, urgent care, and more. So you can filter out the doctors too that take your insurance, that are located nearby, that are a good fit for your medical need that you have, and doctors that are highly rated based upon their rating system. So once you find the right doctor, you can see their actual appointment openings and instantly book a time slot that works for you. Appointments on Zocdoc also happen like super fast. In one case for me, even the same day. But typically, like within 24 to 72 hours, you can book an appointment if you're in a rush. So it's just a super easy way to do it. So this is the product I am now using, and so should you. So stop putting off doctor's appointments and go to Zocdoc.com/metabolic link to find and instantly book a top-rated doctor today. Remember, the app is free. So that's Zocdoc.com/metabolic link. And again, that's Zocdoc.com/metabolic link. Now back to our episode. And then you also couple those modalities that we talked about with red light therapy. And you have a couple different devices, near infrared and IR, but also use a variety of different lasers that can penetrate deeper into the fat. And we talked about collagen, but you really focus on elastin because a lot of people don't, and it is proportionally more important, right, for skin. Yeah, so a laser would be another accessory to most of the procedures that I'm doing on the face. Most people who need a facial procedure also would really benefit from something that's more qualitative. Let's just improve the quality and structure of your skin. Almost everybody can benefit from that over a certain age. So that's often a part of the procedure, but it's also the most superficial, quite literally, that we see. And that's where the red light can have a big benefit on the recovery of those procedures, because red light and near infrared light penetrate into the skin a couple of centimeters, depends on the wavelength. Longer wavelengths go deeper, which is plenty deep to get through where the skin itself is and where the laser is treated, but also to the superficial portions of the fat pads that are also healing into place. So multiple benefits into creating more nitric oxide via cytochrome C. There's a bunch of mechanisms that happen there. Again, it's easy to do. It's a very low risk. It feels wonderful, and it improves our results, right? And it's just especially important with those types of laser procedures. Yeah, I love the red light. I mean, not to mention any there's a number of different companies out there, but also I showed you my my red light hat for hair growth, things like that. So there's just so many different applications, which has for photobiomodulation. I mean, light as and we. Just for the listeners, first thing we did in the morning, we had breakfast, steak and eggs, and then we just, took a walk outside to get those early morning rays. to get those kind of from the red spectrum a little bit shifted more, right, in the morning and in the evening, to sort of really set our circadian rhythm. And I know you're off kilter a little bit from being in a different time zone or whatever. But
that's one of the most light food and exercise. And we kind of pulled all of those levers for me this morning.
Yep. Awesome. So, and you have a number of different other modalities that I'd like to talk about in regard to, you do use some PRP, and you also use PRF, right? And then we'll talk a little bit about that and maybe other modalities with I think that ties into some of the peptides you use too. And I'd like to, peptides are a big topic. I have not experimented with them, but I almost feel like I should, just because people that I know and respect have told me some of the benefits of these things, especially for recovery. So I'm not against using them, but they are potentially on my list. When I tore my shoulder really bad, I was considering BPC-157. I didn't use it, but it is something that I'm considering using because I'm not fully healed, 95, but I'm wondering, your thoughts on these for what you, for recovery from the face and the skin, but also maybe your thoughts on using them for injuries too, which is, the skin is injured, and then you have your short-term injury effects and then long-term. So I'd like to hear your thoughts.
Yeah, and this is interesting because, like I was saying before with the hyperbarics, I'm very, mile deep in my little niche, the world that I live in, but these are widely applicable, to orthopedics and, general surgeries or anything that's happening. And, statistically, 90% of us are going to have a surgery at some point, And the peptides get into that, and some of the modalities, a lot of them have a really strong carryover when we just think of things that have a lot of evidence in wound healing. Hyperbarics being a prime example of that, peptides being an example of that, red light being an example of that. Something like pulsed electromagnetic fields that I use, which is people have heard of PEMF for a lot of things, and it's a little bit kind of, I think there's a lot of wonder around it, but strong evidence in healing, even in bone healing. It has FDA approvals for bone, but it also has evidence in wound healing, and then very small evidence in plastic surgery. And it works via the same mechanism, which is upregulating the extracellular matrix, which is important for the healing process to happen. And so non-interventional, feels nice, helps with some swelling, and helps the healing process. All of my patients get PEMF post-procedure, and that can be great for any sort of soft tissue healing, like a shoulder, or rotator cuff, whatever it may be. And then into the peptides themselves. And BPC-157 has wide applications, but is widely known for its benefits in soft tissue healing, upregulating, vascular endothelial growth factors and things like that. Or thymosin beta-4 or TB500, which you had mentioned, which is just a fragment of the thymosin beta-4, have that activity again. There's so many peptides, right? We could have a 10-part series on just peptides, but these are the ones that are really great for soft tissue healing, and they have forms that are orally somewhat bioavailable, sublingual forms, and then of course the injectable forms that are the highest bioavailability. So
when you inject them, do you inject them directly do they have a local effect? Because presumably, the tissue concentration will be higher at that, or they quickly become systemic, and then that's is there any benefit to using it
especially let's say BPC-157 usually is injected around the site of an injury, but nonetheless you're going to have a benefit regardless of where you inject it. So if you're putting it subcutaneous in your flank or something like that, which is a pretty common application site, it's like you would do for insulin or something. But there is the local effect to putting it right where it is with an injection.
Okay. So these peptides then are, in my surgeon or whatever, the guy that I saw for my shoulder, he was like an advocate of it at USF and wanted to start up research on it. But I knew you can't just get a prescription for it, right? You have to be trained. Is there a training certification for peptides? And I know you can get them at research sites and things like that, but maybe what are your thoughts on that, on guys using it and going that route? Versus working through a practitioner that is prescribing them and directing you on how to use them.
Again, this is all over the map, and I actually, even this part of my recovery, in many parts, I'm sort of outsourcing, if you will. I have an entire functional medicine and regenerative medicine part of my practice that also function on their own, but primarily serve my patients in their postoperative period. So I have a functional and regenerative medicine doctor that I work very closely with, who a lot of my patients actually, when they're having their facial procedures with me, are also having maybe a joint injection with him under ultrasound at the same time they're under anesthesia or something. But a lot of the recovery peptides and things are actually driven by those parts of our practice. Or if a patient's coming in and we want to metabolically optimize them before they come, that's who we're working with, that team, to get into laboratory work or genetic testing, whatever we're kind of looking at before they come.
Yeah.
So I would say, with that open bias is, talk to a practitioner who's very familiar with these, partially because you're going to get better dosing, better efficacy, like how much, when do you take it, and for how long, right? Like if you're doing this on your own, you're guessing or relying on the internet to, tell you what to do, versus having somebody with some experience. So then, is this the right peptide for you? Is this the one you want to be taking? Is there something, more out there? And then of course there's the sourcing. Where is this provider who's, uses it all the time, where are they getting it from versus sourcing it yourself?
Are there unsafe sources out there, like from clandestine labs, or just?
I mean, the answer to that's probably yes in some capacity.
You need to have some pretty sophisticated machinery, to do
correct,
peptides, so they're not coming from somebody's bathtub, like or meth lab or something like that, right?
Yeah, so, and there's horror stories, and there's
counterfeits, I guess, too. I can imagine, right?
There's a qualitative aspect and quality control. And, over the last decade, you've seen a lot of them come and go. There's been a lot more lately over the past 4 or 5 years, but some of the larger players in that field are gone away. And so it's a lot to keep on which ones are which. Yeah,
interesting. So another thing that you do in your practice is targeted IV nutrition, or what we call maybe parental nutrition. And you do vitamins, aminos, NAD, which is interesting to me, glutathione, methylated vitamins, I guess, and then sort of some mitochondrial sort of enhancement, things within that cocktail, neuroregenerative, remyelination kind of thing. So maybe explain how, if that is sort of like, you use the same protocol universally, or maybe you mentioned genetic tests. If someone's a poor methylator, then that's a must do, I guess, right?
Exactly. So this varies a little bit, especially if we have the luxury of having the preparatory time to know a genetic profile. Then it's a very customized situation, even with the type of procedure that we're doing, with or without fat transfer, if it's just eyes or a face. And so it is customized, and there are common threads that run through it. And like you sort of said, everything's meeting at the mitochondria here as well. There's benefits to just the recovery portions of it, but there's wound healing benefits to this as well. We know that nutritional status around surgery is wildly important to what's happening. Even something as simple as you were asking about vitamin D status leading into it. Thankfully, most of my patients, again, especially if we have an opportunity to get into their laboratory work before they come, we know these things. And afterwards, that the IV is strategically timed. There's one the day after surgery, which is important because generally the person was fasting the day before, and they're coming in, and I hear all the time too that helps them just feel better afterwards. The hydration, the vitamins, there's amino acids in there. Again, a little bit customized and depending, but you're right. The methylation part is really great if you're a poor methylator, and a lot of my patients coming in didn't know that prior, and they'll see like really elevated homocysteine levels or something before they come in. And so that's a really great opportunity to optimize their inflammation with something super inflammatory like homocysteine, which is related to their poor methylation of folate, say, and we can adjust that. We can get them dialed before they come in, and then we can know exactly what to put in their IV when they're with us.
Just because it crossed my mind is just NSAID drugs. I mean, coming out of surgery, the inflammation that people may have. And well, I guess around surgery, right, that could increase bleeding, so people are off of them. But what do you see? I mean, so many people use these NSAID drugs. Do you have any opinion on that?
Well, it's interesting. So my opinion generally with any anti-inflammatory like that is I don't want it on board around. And part of that is me believing in the ability to use those inflammatory cascades for good things and to modulate them with the types of protocols that we're doing that sort of make them efficient. We don't want to shut them down though. So to answer your question on an extreme example is it's really common for surgeons, especially in the cosmetic setting, to put their patients on steroids post-operatively, which is really comfortable for the patient. The swelling goes away faster, everything feels and just like looks better. But we also know that on a metabolic and healing level is that everything is shut down. The inflammatory phase of wound healing is not happening or is significantly blunted.
And they're catabolic. So they're corticosteroids, and unlike the opposite of anabolic steroids, which they reduce protein synthesis, which is required for the healing process.
Exactly. So you get this immediate sort of it's like the comforts of slow death. We need to prefer pain a little bit. Like you get this comfortable thing, but it also is quite literally inhibiting your long-term results, collagen production, elastin production, which are wildly important to hit your stride on early on. Which is where, again, flashing over to something like hyperbarics, very simple, like a really great way to modulate that inflammation and actually improve it, which shuts that phase down faster. So instead of using something, and NSAIDs carry into that as well, right? The most common use of NSAIDs postoperatively is pain control, right? Someone may be like alternating between something like ibuprofen and acetaminophen or Tylenol, and so those can go back and forth. And that's a really common postoperative regimen, but I don't want that happening, and so that's where the pain control from my other, nerve blocks and local anesthesia really, and reducing inflammation with hyperbarics and my PEMF, those all help the postoperative pain, and hopefully don't need any NSAIDs afterwards.
And the sort of concerns with NSAIDs are, well, there's the GI issues and then the bleeding potentially too. Right, but what about like something like naproxen sodium, right? And you could take, that's like a long acting, like a small dose of that, or I guess what's the concern with the NSAID drugs? Because you are a very light, no opioids, no benzodiazepines, so patients, so that's a big, they're big hitter drugs.
They are.
So, but you are using other things that are more progressive, right? But I was just wondering, just for all the people probably who use NSAIDs out there for different, ibuprofen, it just seems like people take them like candy.
And naproxen.
Naproxen sodium,
and it's the same in that post-op period where it's interesting because more of my patients are using those for joint-related arthritic things, and so I will have a significant portion of patients who are coming, again, partially because they're also seeing Dr. Meadows, who's my regenerative medicine doctor that I work with. They're seeing him as well, and he's doing a ultrasound guided joint injection with their fat-based stem cells, the same ones that I harvested. He uses some of, and so there's a little bit of a selection for patients with osteoarthritis and who are using these, and it's interesting though that their need for them, that's part of the goal, goes down in the postoperative period because of those injections. And but again, I want those inflammatory cascades at full function.
That's the main thing.
I don't like to use them.
So I think a really big lever for recovery that we're both very passionate about is exercise, right? Exercise, you have activity-induced BDNF in circulation. You have, just the sheer movement aspects of it, the blood flow aspects of it. How do you approach transitioning your patient, getting back into exercise if they've already exercised, or if they don't exercise, to kind of do some preoperative to if you could boost their metabolic health a little bit going into surgery, that could pay big dividends on the outside, on the other side, right? So,
big time, And so this is a good question of a pre and a post, because in the post-operative period, you mentioned BDNF, that's a big part, even from their neuroregeneration, go back to the POCD, the higher their BDNF levels, the more protected we are. They're neuroregenerative, it's fantastic. One of the medications that I use in particular also increases BDNF levels. Great. This is the anesthetics. So we have an increase in BDNF levels from the anesthesia itself, and then I have them walking as many steps as they can tolerate, if you will, immediately, right? And that's not like they're taking 20,000 steps at day one, but in the first couple of weeks, that's their main form of exercise, which has so many benefits outside of just, kind of keeping their mind off their recovery and letting, again, I'm working with patients that high achievers, people that move, people that are interested in their health. And so this is, we would go nuts if we couldn't move for 2 weeks, right? And so it falls into that very, very well. But this does get into the pre-portion as well, right? How are they coming in? And this has been a big curiosity of mine, that I have worked with a few patients who are very proactive on their exercise, and I kind of picked this up and know this beforehand, but just like even hypercapnic tolerance, like before they come in, what's their CO2 tolerance before they come? And then working a little bit on getting that CO2 tolerance built up before they come in, which again, this is like in my head theoretical, but also playing with, is this going to help their anesthesia and their anesthetic recovery by having that little bit of hypercapnic tolerance?
Can you do, I mean, there's different protocols, like
it could be as simple as breath work,
Buteco breathing, right? And then like controlled pause, or like breath work is
breath work. So I kind of break it into the breath work types of options, which sometimes even like box breathing can fall into that if it has portions. And then there's just, even walking while nasal breathing, or pausing while walking, or zone 2 exercise with the nasal breathing focus, which people hear about and you're like, I think I do that, until you pay attention and you're like, nope, I don't do that. It's an interesting sort of build up, but again, that's a very collaborative effort with my patients leading into it.
So I don't think we touched upon it, but your hyperbaric oxygen protocol, like they come out of surgery or pre-surgery, and then because not a lot of people have like a hard shell hyperbaric chamber. So how do you get them into, like, what kind of, and for how long, how many sessions?
So in the preoperative dive is, and if I were to just kind of lay it out, the preoperative dive, we're trying to get them as close to 2 atmospheres as they can tolerate. And most people can kind of get there. It takes maybe a slower kind of dive time to get down to that depth. And that's a really great place to kind of get familiar with. Post-operatively, when they're swelling and things like that, we're titrating it, usually starting at a lower or more shallow depth, but a lower atmospheric pressure. And then we're working back up to that. And so roughly I'm starting at, for all of my colleagues out there who are watching or whatever, I'm usually starting at about 1.2 or 1.3 atmospheres, 1.2 to 1.3. And sometimes I'll, titrate up from that a little bit even at day 1, depending on the patient's tolerance and what procedures they had, right? If they had smaller procedures, they can usually get deeper faster, with the goal to be to 2 atmospheres by the 3rd day. And the goal in that first week is to get a minimum of 5 dives in at about 90 minutes apiece. And that's what the evidence shows is the most beneficial. There's some data in my type of a setting that is like, elective for recovery types of procedures that up to, 13, 14 days is, you can get benefit into that time. I mean, I honestly believe you can get benefit at any point. But when we're looking at sort of like proverbial bang for your buck, it's that first week or 2. So I'll have patients that go home, and then we're looking for hyperbaric facilities near where they live that they can go to. It's really convenient to come with us, obviously, but when they get home, sometimes we'll find ways to continue diving.
Yeah, that's right, because people are coming to you and kind of staying during that procedure. And then something that they can do is like nutritional supplementation, right? So there's just maybe a few things, like we talked about the peptides or whatever, but supplements like melatonin or creatine monohydrate or exogenous ketones or something like that. So what are your
so those are
home with or general recommendations?
So those would be things that I like them to start again in the preoperative period. And so what kind of happens is we get dates set and we start working towards that time frame is we'll send them kind of here, here's your sort of preoperative kit basically of things to take. And creatine has been a interesting, I would say a more, again, this is the real like focus of my playing right now, has been a more recent addition, comparatively, and really popular because a lot of people have heard of it, and again, some are very familiar with it. If I sent you creatine, like, I got so much, I'm very used to this, right?
The most tests have been using since 1992 or 93.
With an incredible safety profile, right? But the interesting thing is it's been so focused on performance, right? Muscular performance, athletic performance, but we know that it has neurocognitive benefits, sleep benefits. It's an energy source for us too, right? And so to have somebody started on that coming in, maybe for the first time, we know that I'm helping their recovery, helping their sleep, helping their neurocognitive function, again, into POCD, into sleep, it's like it's been a wonderful addition, basically, for that reason. I don't know anybody else that's using that, and I hope that becomes just standard widespread, like, why didn't I think of that? Melatonin falls into that too, because we think of it as a sleep supplement mostly, but it's also a really strong antioxidant.
For sure.
Which is, I think, some people know that, some people don't, right? And so double benefit there as well. Better sleep architecture, better sleep structure.
Neuroprotection. I studied it for that, looking at the hippocampus, in response to oxygen toxicity. So it knocks down free radicals, in the hippocampus.
Which is a very specific brain region that a lot of anesthetics will target too, the hippocampus. And so important for memory, consolidation and things. And so that's another multi-benefit. And I love it because you have the better experience for my patients, and then also better outcomes in the long term, which is the later down the road appreciated thing. So, yeah.
Well, I would like to pivot a little bit, and because you practice what you preach in practice, if that makes sense, right? So what you actually convey to your patients, some of these modalities for wound healing and things like that you personally use for optimization, just for general health, but you have and you describe to me in a lot of detail, sort of. So your approach is like to prep, and you do a very comprehensive prep, and then execute, and then recovery. And I can imagine after a long surgery, you just need a full day to just like recovery or whatever. Right. But maybe tell the listeners, because I think this could apply to everybody, sort of your preparation for such an important procedure where you're taking on such a big responsibility with the person's health and their appearance and the expectations. There's a lot of physical, mental preparation involved in that. So what protocol do you use for that?
And that's a good point. You sort of just mentioned there is, I think there's only a few times in life that, especially as adults, where we quite literally put our life, if you will, in somebody else's hands with no power. Like getting on an airplane, we even do that, but surgery is definitely one of those things that is very much not lost on me. And I really value, this is something that's come with maturity and time for me, is really valuing and digging into the relationships that I have with my patients. And so it's not just like, the case that day. It's like, I know this person inside out. I know their family. It's an important connection. It gives me a lot of life and work value. I love that, right?
And you schedule your procedures so you're like all in. It's not like you're trying to hit 3 or 4 in one day. Like you're all in one day. Like everything goes into it. Like every kind of mental, physical, and every part of your being is like part of that your entire day, and that personal connection that you have with the patient too.
And it's that kind of back to that, like life as a professional athlete. This is my event for the day, my game, my my championship or whatever, and for some intents and purposes, like my life kind of revolves around being ready for these procedures. My emotional and cognitive outputs, I'm tailoring towards when I need to be at peak performance for surgery. My physical outputs, like my workouts and exercise, and I'm monitoring those very closely with my ring, with my levels, and I'm looking at my blood glucose as a metric of stress for me, really, to know like I have a surgery Wednesday, and it's my Monday workout. My blood glucose was too high for too long. That shouldn't have happened. I'm stressed. I need to alter, right? Or sometimes I'm like, I'm really well recovered. Let's go, So anyway, it's all about kind of getting to that moment. And then the day of the procedure, I'm really big on visualization, which goes back to sports. And the type of an athlete that I was when I was younger was, very sort of like, visualization was a big part of it, as a place kicker or a golfer or something like that. And then, there's visualizing the process, there's visualizing the outcome. I do these in peace, kind of like in just my mental preparation. I also do them in stress when I'm in an ice bath or in the sauna or exercising. And then, the day of the procedure is, kind of it boils down to, I call it a flow state preparatory phase to get into flow state. If we really wanted to get into it, it's probably actually less of a flow state, because it's more of like a time where I'm in this like calm preparedness. It's like neurosynaptic coherence type of thing, but it's not probably actually flow, because I'm working, right? It is effort, and it is because the flow state is sort of an effortless, timeless type of thing. This is like a lot of decisions coming at you and having to make them, but just in a very calm, calculated way.
But you've done the reps, so you're kind of on autopilot to some extent, but every surgery represents like a new and unique challenge that you have to be flexible, because I'm sure sometimes you cut open, it's like, oh, what is that? Or like you might see like, a filler, like, yes. Or various granulomas underneath that, like that you didn't intend for, and you have to,
Yep.
And that's adds time, and then additional anesthetic. There's just like you have to be
ready to roll with those.
And you visualize up to a certain point, but you need to be. We call it, I don't know, operationally when we were doing different missions and stuff, it's like flexecution, I think, being flexible, but that flexecution kind of adaptive response.
That's exactly right. I like that term. Flexecution, and that carries into, it's funny that you say that, because then after the procedure's done, like everything's over, I get in my sort of focused flow and I'm done, and when it's all said and done, when I get to the other end, I kind of go back through. And in that going back through, I'm journaling, basically. And there's my medical note that's like what I did, kind of like, but then in my personal journal that I take after every procedure, it's a little bit more reflecting on the flexecution. Like, what decisions did I make? What did I come across? Because then when I get to the end result, which is oftentimes 6 months later, a year later, then I get to kind of actually get feedback. Because that journal becomes really important, where I get feedback later on. And, I call it watching film, where like an athlete does, like, except my film's not the next day, it's 6 months later.
So it's like your lab journal, kind of like you kind of summarize your, mental state, how the, what you did right, what you did wrong, or if you did wrong, or like what you can improve upon, kind of thing.
It's sort of like, I saw this on the left side and it was different than the right, and I made this decision to do this, and I noticed that there was some filler on the side more than like whatever it is, and so here's sort of how I navigated that, and then I get feedback.
And you describe levels, and I wrote it down here, as a systemic stress metric that you kind of use to just assess your readiness, I guess, looking at your blood glucose response, and then just from the morning response or response to food, and then coupled maybe with your HRV, and then other, subjective things too.
Sleep and all the things. Exactly. Okay. And I use that, it's interesting to watch, because I will compare it to, like I've done, where I'll wear my heart rate monitor during surgery and monitor my heart rate and my blood glucose, and I can watch how those parallel each other and see when heart rate comes up. And, what is interesting with my blood glucose is when I'm in surgery, it goes up and sort of stays flat and level, but it's elevated. I'm ready for performance in there, which again sort of probably argues against that flow state idea a little bit. It feels like that, but I'm activated, I'm ready. And then the same thing with like you're saying, HRV and heart rates. Those are actually significantly more fluctuant throughout the procedure. It's interesting.
So being kind of having high metabolic flexibility, being keto adapted, being able to fast or be on a carb restricted diet, I know for me it has helped from an operational standpoint, from an academic standpoint, from an experimental standpoint. If I'm in the lab, for example, in the vivarium, like where there's no food allowed, and we get tied up, and 6, 7, 8 hours, 9 hours goes by. My blood glucose dropping is not a crisis situation, right? It's not an emergency. So I can imagine that in certain scenarios where you're not like eating, like in Seinfeld, like the mini, the mini, where it popped into the guys. So do you fast going into your procedures, or do you?
I do. I do. So the metabolic flexibility is big in that, and being keto adapted, and it depends on the procedure a little bit. And like you're saying, like I would rather be in ketosis going into a procedure because they're longer sometimes. They can be, at the minimum they're 5 and they're up to 10 hours long, right? And so just knowing what knowing what I know, is like, what would I want my surgeon doing there? And different colleagues that I have handle this differently. Some will stop during their procedure and we call it scrub out, like take off their stuff, leave the room, go to the bathroom, have a bite, whatever it is. Others will kind of push through. And I'm in a state where I do not want to be interrupted. And so I push through.
So you have to regulate your fluid consumption, like maybe a little, like, I don't know, injection of aldosterone or something. I don't know. You know how to, there's certain things that I know to do, like if I'm going to be a flight and on a flight, a long flight, and I'm like on our window relative or the middle seat or whatever, I know various little tricks to just trigger water retention, or just I'll water restrict or things like, I mean, you must do that.
I do.
Because that could be a big disruptor, being halfway through surgery and having to, run to the John or whatever.
And that's like the first thing I do in the morning as I'm getting up, is starting that sort of fluid consumption with a cutoff time.
Okay.
And I know it's approximately 120 ounces before a certain time preoperatively, and I know that I clear it out, and then I'm kind of good to go. And that's like my...
Do you like sodium load? Or actually, for me, like a little bit of carbohydrates, or like a salty fatty meal, like with cheese in it for some reason, like dairy kind of makes me hold water a little bit. So like a little bit. So I just know there's certain things that I know to do, like to basically not have to, kind of urinate for the next like 8 to 10 hours.
And I do use sodium.
I don't like to do that, but okay. But you have to do that, and that plays a big role, because once you get into that flow state, that can be disrupted if you have to break from that and scrub out.
And you'll see... And I'll see it, I've seen it my whole life, and kind of, maybe you don't put your finger on it as much, but, and it makes sense, is you get in a longer case. This is like back to when I was a student or a resident or a fellow, and you get into a longer case, and things are getting, later in the case. It's been a while, something challenging happens, and you see a different reaction from the surgeon. Like a more irritable, or throwing an instrument, some egregious thing like that. Like you see that emotional toll and the psychological toll and the cognitive toll taking effect. And in hindsight, I'm like, they're also probably really struggling with their blood glucose at that point, right? It's been however many hours, and they're probably not very metabolically adapted, and so I want to be rock solid. This like does not even cross my mind, regardless of the length of the case. I'm fueled and ready to roll. It doesn't, I'm sharp, and there's none of that's affecting it. And I feel that now, and that took effort and learning to get to how you can do it for that long. And I guess a desire, just an awareness to even get there.
So you practice really, it's like ketogenic, metabolic, regenerative medicine. And I mean, you practice on yourself, but also in your patients. So there's a lot of the modalities that you use on yourself, with nutritional ketosis, supplemental ketosis being kind of a really big lever for performance optimization and recovery.
Which is, again, back to the very, like, bringing it full circle. That's how I found you in the first place. It's like, how do we get to, how can I, like, metabolically optimize myself for these types of procedures? And I was an endurance athlete prior, and so I had some familiarity with ways to do that, but it's very different in that setting, where you have the ability to kind of continuously be consuming, and, it's for a different purpose. This was... in some sense, sort of changed the way that I performed and practiced quite a bit.
Yeah, I mean, I talked to pilots, race car drivers, special operations communities, guys that really leverage that. They said, like, this was the thing that, got me into that flow state, that focus, that allowed me to execute and be the person that they needed to be during that time period. So that's awesome.
And that's what's carried into my patients, was my own personal, I was telling you, kind of joking offline, I was like, the story that Tim Ferriss told about you deadlifting an astronomical amount of weight while deep in ketosis, and talking about, performance optimization that way. And something that's kind of always made sense to me, I've kind of felt like we should be metabolically flexible to use all of these different sources, probably primarily ketones, with some glucose, with some lactic acid, with some whatever else, and that hit for me, back then.
I mean, prior to getting interested in this topic and just thinking about fasting, it seemed so counterintuitive that I thought if you fasted, you would just be sitting on the couch in like a vegetative state or something, not having the physical or mental energy to do anything. And the more I was doing it, the more I realized I was deriving benefits from it, and the easier it was getting. And I probably took it too extreme a couple times, and I don't do that anymore. But I pull that lever here and there if I have to be up early, and just fast throughout the day, and just eat later in the day if I have to. But if I do it too much, I just lose too much weight, or can produce too much of a caloric deficit. So I just, and I actually think to where I'm at now, it's better if you do it all the time, then I feel like I don't get the optimal benefits than when I pull that lever, right? So it's like I can pull that lever when I need to, and you're probably doing it, during your surgical days or when you have a complicated case or something like that. So
and I have kids, and so it's all they're familiar with, they're used to, are you fasting, or it's kind of cute, and they're very involved with, they want. What'd you do? Did you do this today? So there's, and it's interesting because you get to pass some of those performance and, this honestly, again, full circle, the same curiosity that I had when I was a kid that my mom created, whether she was right or wrong about things, that like at least made me go into it critically thinking.
Instilling those values in them too. It's also like sort of a sense of control, but also just, the exercise that you prioritize too, and just like, the family values and things around that. So. Well, did we not hit? I know there's so many other things to talk about that you've talked about, like on other podcasts too. Are there any other topics that you know?
I mean, from a metabolic standpoint, that was a good. I think that's a lot
overview.
Again,
maybe tell people like the surgeries that you do the most, right? And just kind of so people we didn't get super deep into exactly what you're doing,
because people are still watching at this
a lot
point,
about that. Just like a summary of your most common things that you do.
So, and as you get into call it like any reconstructive plastic surgery types of fields, there's different ways into it. There's general, which has a lot kind of whole body. There's eyes and faces, and there's multiple routes to get into it. But the one thing they all have in common is they're kind of 3D spatial, reconstructive, with a cosmetic angle, and I love it because everything's a little bit dynamic and different in this, right? And the reconstructive part is what I think a lot of people know is attached to plastic surgery, but they all think of the cosmetic end. And as we get into the cosmetic end, I'm very small world. Faces, and specifically this is important, rejuvenating procedures, not transforming procedures. So a breast augmentation or even a nose job or rhinoplasty are changing something that was never there before to a new form. And I don't do those types of things. I only do rejuvenating procedures. So as we were kind of talking at breakfast this morning, I was saying like, if I could put it in a nutshell, I kind of like move fat pads back to where they used to be, qualitatively rejuvenate the fat pads and the skin, and I try to do it through as minimally invasive of a way that I can. This is like the Pareto principle, the 80-20 rule. I'm always thinking that way, like how do I get the most impact with the least invasiveness? And then kind of understanding how all of those things work together. So
the less risk too.
Right, everything. The recovery's better, the visibility of any procedure is like more natural or like harder to detect. And there's some insulating factor to that too about not overcorrecting, right? Because I built a ceiling that I kind of can't go above, and the ceiling is very inbounds,
and the potential to do serious harm too with some of the other procedures that you mentioned, whether implanting a silicone implant or doing a rhinoplasty or other more invasive. And I can imagine that the insurance for that, the medical insurance, I'm not sure how it works, but I mean that's a pretty big liability, and you're taking there's a lot more potential for things to go wrong during the surgery, and also for like infection and like other things down the line too.
I choose not to use any foreign substances that I implant. I don't use implants. I don't use even permanent sutures in my procedures. I use, we were talking about polylactic acid. I use things like that kind of get metabolized and let the healing capacity of the body kind of keep things in place, because the sutures ultimately don't do anything anyway. In the long run, it's all the healing capacity that happens. And that's again part of my personal values being projected into this. Is like I don't want to put something foreign in. I want it to be as naturally held together. And so to get to your question, it's a lot of eyelid rejuvenation, face, neck, and that is everything kind of from the hairline, forehead, brows, excuse me, all the way through faces, jawlines, and necks. So
will you pay extra attention like around the eyes and various aspects of the face that are involved in nonverbal communication, right? Because we see people that just look like they got stung by a bee. I mean, their face is all puffy and frozen, where they're just like over Botox, over fillers and things like that. Like we see it, but then there's, the person's perspective shifts because it's sort of a societal norm, I guess, too, right? So you don't want to be involved sort of in that psychological kind of, I don't know if perceived as a problem, I guess, in plastic surgeons that do it, they see it as like an advantage, but maybe taking an advantage too. So you're restoring what a person already had, as opposed to
trying to make something
and try to create something.
Yeah, and you touch on a lot of things that I'm like supremely interested in. Now we're getting to a very foundational level. Like I'm very curious about the neuroanatomy of how we interpret with faces, and nonverbal communication overlaps with beauty, and even like mate choices, like attractiveness, and how all those fit together. And you're kind of like hinting at distortions that happen with that, which is funny because, go back to, the 70s, 80s, 90s, like if you saw somebody whose face was distorted, like they had bad plastic surgery. That was like what everybody thought, right? Yeah. Now, and I see this really commonly, most of the time when I see somebody being attributed, like something that looks odd being attributed to bad plastic surgery, ironically, it's usually actually bad filler, or sometimes bad, Botox, but it's usually filler. Like now we see like these distorted faces that are coming, and it's this like non-surgical treatment that they're getting that's going overboard, out of bounds, poorly understood.
I almost saw this like over 10 years ago, and I was like, what is going on? The lips, the lips, face, and it's almost become like almost a societal norm, especially in LA and other areas, where, and that can't be, it's got to be painful. It looks like it's painful, but it also, it just seems like, I know when you look at neurologically, like a homunculus, where it shows like your lips, there's so many nerve endings and things around there that it seems like it could interfere with other aspects of, your eating, or just like, intimate things, or like it's just
and it's interesting because
people look at your lips when you're talking too, and it's just part of the nonverbal communication between individuals, and that's
you hit on that's the primary one. Like the homunculus, for people that don't know, is like you can map out our brain and where the sensory nerves are, and there's this kind of cool image. You should look it up. It's kind of fun. But lips, fingertips, those are like big areas. But it is the nonverbal, right? Because when we get back into that neuroanatomy of how we're interpreting, anything that happens around our eyes, or especially our mouths, those two areas are our primary areas of nonverbal communication. Even if we get down to the nitty gritty of like how our facial musculature is organized in those areas, those are the primary areas where all of our muscles of facial expression are moving, our lips and our mouth. And right around our lips and our mouth, the muscles attach directly to the skin with very little insulating factor, so you can get the most fine movements, and whether we know it or not, we read them, right? And so, interestingly, most of our facial interpretation isn't coming through our frontal lobe. We're not really deeply assessing it. It's kind of more in these regions that are related to facial recognition, communication, emotion, reward. And so if somebody's face is off, we've all experienced this. You may not be able to put your finger on it. It's like, it's kind of hard to explain, but you know it when you see it, type of thing. And that's quite literally, it's the core sections of our brain, our temporal lobes, not our frontal cortex, which is different than when we look at beauty that is architectural or art. We have a different part of our brain that lights up there. But we notice those things, and the lips are a big one there, and they're maybe the most common area that people seek filler or something like that first, because it's a little bit of an augmentation more than a rejuvenation. Like, I kind of want my lips a little bit bigger, especially if you're seeing somebody in their 20s or 30s doing it.
Is it always women that have that, or do guys get lip filler too?
More commonly women, but guys do it too.
Okay.
And
I might have seen like you just maybe on Instagram or something, but I can't remember seeing like
lip filler is more predominantly women, and if you get into other procedures, there's more evenly matched sort of like breakdowns. Lip filler is probably more predominantly women though, but it does throw off that perception. If you think of other primates, like lip smacking or something, one of their main ways of communicating, we're just like so in tune with what's happening with lips, and you just want to be really careful in those areas. And the eyes being the same, but that's also really great when we understand that, because I can now really understand like fine little levers, back to like pulling fine little levers without really doing too much, but having these really big impacts. And my practice is built really on before and after photos or videos or whatever, like the results, right? And that's what my goal is. And I think when a lot of people go look at those results, that's what they'll see is like, that looks better, but I have no idea what happened. And that's like kind of understanding that neurocognitive assessment and the neuroanatomic approach and trying to pull the levers subtly.
Yeah, and I guess also looking historically as, the pictures of the person in their 20s and 30s and everything, and let's move towards that direction. And it may not be all done in one procedure. I can imagine like there may have to be like consecutive procedures to achieve that final outcome what they want. And
just depends.
But if you modify one area of the face, but other areas are lacking, right? It just seems like that could be a distortion. It's like, well, that looks fresh, but wait, this is sagging over here. I think your brain, I can't put it into words, but I've seen people where there's just asymmetry or just something is not right.
Yeah, you're like, I don't
know how to verbalize it, but there's just something off there.
This is like second and third order thinking now into it, and this is a big part of my job, if you will, is helping somebody navigate how to not make that happen, basically. And I see all the time where, you're right, somebody has a procedure done and then there's a mismatch. And so there are ways to decouple things and kind of like focus on an area, but you have to deeply understand how to do that and what procedures need to go together to make things move smoothly and
like
be natural.
The eyes bring up, but then they still have the saggy chin or like the skin around here. It's like, they have like, one particular area, but other areas are not.
And so that's a big part of my life.
And
so I'll usually ask people like, hey, if you had a magic wand, what would you do? And then once I kind of have that, I'm like really seeking to understand what their end goals are, and then I get to fit it all together. Like, okay, here's how we can actually make that happen. A really common example of that would be somebody who has kind of overall facial aging. Everywhere is aging, but they're really focused on their jawline and their neck, which is sort of the most like gravitationally downstream. And they're like, well, I just want like to lift up my face and my neck. And I'm like, okay, I understand that. But if we lift up your face and your neck, you have all this redundant other tissue falling on top. And we quite literally create a delineated line of elevation against descent, and we can't have that. So it'd be like a really prime example of like trying to help navigate what that looks like.
Wow. Yeah, it must be fascinating. Like each person represents a unique challenge and in regard to, what you can give them and their expectations and what surgical things.
And you hit on the best thing earlier, which we kind of skipped over, which was I just want to see younger pictures of them too. Like I want to see 20s, 30s, 40s. I want to see every decade as many as I can get, because now I have not only do I have targets, but I get to see the trajectory of how things changed, and I get to know like, okay, here's when this happened, and we age for a lot of reasons. This gets into a whole nother topic now, but
well, you described sort of restoring the person to what they already had, but I can imagine like people are coming in with pictures of celebrities, just like, I want to look like this, I want my cheekbones to be like that, and I want or this or that. So,
I think that's like a very.
I guess you don't even do that.
I don't even do that.
You're just focused on
That would be one of those like.
I can imagine that
plastic surgery.
That's what everybody does, but this is totally different from what you do.
Exactly, and I think that probably does happen to some people. But in my practice, that's just honestly not even a discussion. Yeah. So I'm like, well, I'm not trying to make you look like so and so.
Yeah.
Let's see you when you were younger. Yeah.
Awesome, man. Well, you are taking surgery, facial plastic surgery, to the next level, right?
Thank you.
From so many different perspectives. And it really blew my mind, when we connected and we conversed the first time, and I think we just jumped on a Zoom call, and then you sent me notes, and it's just like, man, this is definitely next level stuff. So I could see why people seek you out to have that relationship to build, and then for them to, put their one of their most important assets. I mean, how into your hands, and that's a pretty big trust that you build with them, and all the different modalities. Right, it's just really fascinating, because I think it has a carryover effect to not just plastic surgery, but I think every surgeon should. Orthopedic surgery, they should be doing this. Like, orthopedic surgeons have reached out to me, cardiac surgeons, and nowhere near like the comprehensiveness that you approach it, but they've implemented ketone metabolic therapy or hyperbaric or different aspects of that, and so it is catching on. So
and something like a cardiac surgeon with ketones have a whole nother avenue there, right? Yep. And that would be like one of my like life and career goals, is to help this be. Like I get reached out to by like an orthopedist who's like so excited. I'm like, do this in your field, like lead this way, because I think it's just wildly applicable. And surgical practices and training are hard, especially when you're operating in, I don't know, a hospital system or through insurance. Like, it's harder to do those things. I'm afforded the luxury of being able to be curious and experiment and have patients who are, and these aren't like crazy experiments, obviously, but just like exploring ways to make things better. And, you know, that the hope is that they can become things that kind of catch on.
Yeah. Well, thank you for sharing your wisdom, your experiences, your personal, kind of procedures that you do to prepare for that and then execute. And then I'm sure we didn't talk about how you recover in downtime, but I'm sure, you need to do that, especially with 3 kids, a wife and 3 kids, and a busy practice that's growing really fast, I'm sure. So I want to thank our listeners too for, watching this. And this was a really exciting area to explore for me, because we didn't have a plastic surgeon on that covers this topic, and I had a lot of questions, and Cameron and I talked offline about many different topics, and we might do like part 2 too.
Yeah,
so
absolutely.
to cover this,
because I have some questions for you in part 2.
Okay, awesome. Well, thank you. Really enjoyed our conversation.
Thank you very much.
Thank you for listening and watching this episode of the Metabolic Link. If you like this episode, please leave us a review, and don't forget to subscribe to our podcast for more of the latest science on metabolic health and therapy. If you want to enjoy exclusive episodes of the Metabolic Link podcast, please check out our membership platform at membership.metabolicinitiative.com for hundreds of videos on the metabolic health website, and also videos on metabolic therapies. There's a live Q&A with world experts that answer all your questions. We have ebooks on there and much more. So thank you again for joining me on the Metabolic Link.
Do you love learning about metabolic health? So do we. It's why we created the Metabolic Initiative, an online educational platform providing evidence-based education on metabolic health and therapies for healthcare professionals and the general public. By joining the Metabolic Initiative, you'll gain access to hundreds of expert lectures, interviews, panel discussions, and even private episodes of the Metabolic Link. CMEs are available. Go to metabolicinitiative.com to get started. And as always, thank you for listening to the Metabolic Link.